Welcome, everyone, to the opening session of the 2024 Colorectal Cancer Community Conference. This session, entitled New Advances in Colorectal Cancer Treatment, has consistently been the most requested and the most favored session of the conference, as our medical panel will be providing an overview of the latest available treatment for metastatic and non-metastatic colorectal cancer in Canada. We know that many of you watching today are newly diagnosed, so this session will help you to understand the many treatment options, some of them still in trials, that are available to you to discuss with your own medical team. Our medical panel will also provide guidance and perspective on how, pending an individual's personal diagnosis and stage, what the best approach to treatment might be. This session will run for a total of approximately 65 minutes. We have an outstanding panel of 3 oncologists with us today, and we'll hear from each of them about their work and areas of focus. From there, we'll open the floor to questions, so please do make a note and post your questions in the Q&A section of this platform. Let me begin by introducing our 3 oncologists. First, Dr. Patricia Tang, who is a medical oncologist at the Tom Baker Cancer Center and a clinical associate professor at the Cummings School of Medicine at the University of Calgary. Please welcome Dr. Eric Chen, who is a medical oncologist at Princess Margaret Cancer Center, University Hospital Network in Toronto. And also from Toronto, Dr. Paul Karanicolas, who's a surgical oncologist at the Odette Cancer Center, Sunnybrook Hospital. I'm going to begin with Dr. Tang, and we're going to open the floor to a conversation about tumor boards, which is one of the topics that actually covers virtually all cancer types, and specifically cancer types, and to learn a little bit more about what they do, how they work. So Dr. Tang, if you could educate us a little bit on that topic, that would be terrific.
So tumor boards work fairly similarly across Canada. There's usually a radiologist, access to a pathologist if needed, and physicians from all the specialties, so surgery, radiation oncology, and medical oncology. And so complex cases are discussed. Sometimes each individual doctor brings up a case where they want input from a larger group of experts. Sometimes, for example, in Calgary, we actually try to routinely discuss all rectal cancer patients in a multidisciplinary fashion. So we discuss all rectal cancer patients, and sometimes medical oncologists or physicians from community cancer centers bring their case for discussion. We would be considered a tertiary cancer center, so they can ask for their cases to be presented if there's questions with respect to optimal management.
Now, does every patient who's diagnosed with cancer go in front of a tumor board? Is that a standard practice?
So I guess in an ideal world, but I think definitely there are some cases that are very routine, like adjuvant colon cancer, where the multidisciplinary discussion is likely not warranted. But for complex cases like rectal cancer, when there's the 3 specialties involved: surgery, radiation oncology, medical oncology, or for example, liver-limited colorectal cancer, where there might be surgical options, or when we're considering a resection of a metastatic site for cure. So definitely the more complex cases, but unfortunately, we don't have the capacity as a system to discuss every single patient. But I do think it is an alternative. Sometimes patients, want to be seen, for example, in a tertiary cancer center like Calgary, but they live in far away. So they don't have to travel. We can discuss their case and present the findings to their community oncologist if there's a question. But unfortunately, we just don't have capacity to discuss every case.
Yes, yes. What is the benefit to the patient, do we think, of having their case discussed?
So sometimes, of course, different people bring different perspectives, and may have thought of an aspect of care that, a slightly different pathway to care, for example. And for community patients, sometimes it's just for more complex cases. It helps guide the community oncologist with next steps, or provides reassurance to a patient if they're wondering, is this really the right thing to do?
I see. So a patient would actually be aware, if they're being treated, that their case has gone before a tumor board. Their oncologist would let them know that that's happened?
Yeah, well, often we tell the patient, this case is very complicated. I would like to discuss your case, with my colleagues, and most patients are, very happy for their case to be discussed, and then we would discuss the findings with them after. But yeah, we would inform the patients that their case was discussed. I guess that's a note to my own practice, because we discuss all rectal cancer patients, that I don't actually always verbalize that, oh, your case was discussed in tumor board, and this was our consensus. And self-reflection, I will make sure I'm verbalizing that to the patient.
Oh, what a wonderful comment to make. It just seems like it's a beautiful peace of mind to know that you've got a full team of wonderful minds in a circumstance that oftentimes is very difficult. I know that you're in Calgary, Dr. Tang. Dr. Chen, maybe you could comment on the Ontario experience. Is it common, tumor boards here? Is it something that is as perhaps as prolific as it is in Alberta? Is there differences by province that you're aware of?
No, I don't think so. That I agree with what Dr. Tan has said. That ideally, every new cancer patient case should be discussed in a multidisciplinary fashion. But the fact is that we are limited in terms of our capacity. So not every case is discussed, but cases require multidisciplinary care, such as rectal cancer, such as colon cancer, require possible for surgical resections. That those cases has to be discussed that in a multidisciplinary fashion. And no, I agree that different specialties do bring different perspectives and expertise, and patients will benefit from it.
Yeah, thank you so much. I'll give you the last word on this, Dr. Karen Nicholas. Is there anything you'd like to add with treatments evolving so quickly and having multidisciplinary team? It is hugely reassuring, I would imagine.
Yeah, absolutely. I mean, it saves patients, I think, from having, has been alluded to, it saves patients from having to travel around and see 8 different doctors to get an opinion. You can really get the opinion of multiple doctors from multiple specialties. And now with virtual care, even from multiple centers, contributing to the discussion and contributing to ensuring that each patient receives the best care. So I think, particularly for patients who have complex problems or problems that require doctors with different areas of expertise, be it chemotherapy, radiation, surgery, or interventional radiology techniques, I think those are the patients who likely would benefit most from having their cases discussed at a multidisciplinary case conference. And I think patients could also ask their physicians if they have had their case discussed. And if not, I think it would be fair to ask their doctors to discuss their case, and they can then be reassured that they are receiving the best treatment possible.
Yeah, thank you very much. I like the idea that it's okay for a patient particularly who's been newly diagnosed, to know that not only is this option available, it's something that they can proactively discuss or table with their oncologist. Thank you so much for those wonderful answers. Dr. Tang, let me go back to you and ask you to talk a little bit about this area of non-operative management of cancer cases, and who presents as candidates for that? How is the assessment of that process done?
So that pertains mostly to rectal cancer and mostly to low rectal cancers, where the surgeon feels, and again, I'm a medical oncologist, so when the surgeon feels that the patient may need a permanent colostomy after surgery for their rectal cancer. There is emerging data that some patients, if they undergo chemotherapy and radiation, can have a complete clinical response. So if they're evaluated both by a scope, where they take the little camera and they take a look in the bowel to see if there's cancer left, by imaging, and that would be CT scans and MRIs, and physical exam. So that would be a digital rectal exam performed by an experienced surgeon. Patients who have a complete clinical response based on those three types of assessments, instead of proceeding to surgery, which is gold standard, that is the standard of care. Yeah. Some patients can avoid surgery. So there was a trial, the OPRA trial, or Oprah, and approximately 54% of the patients managed to avoid the surgery where they would for their rectal cancer, and they had a complete clinical response. The data is still early. We need longer term follow-up. So that basically means that they didn't end up with a colostomy or a permanent bag, basically. I think it's an emerging concept. Not all patients are eligible based on anatomy. So patients, some patients unfortunately have too locally advanced of a cancer, and it doesn't shrink enough on our treatments. So, our gold standard recommendation would be to proceed to surgery. And avoiding a colostomy is great, but I think we do need to recognize that with the treatment, the chemotherapy, radiation, there are side effects. And so there may be still problems with accidents, bowel and bladder. And our treatments can cause sexual dysfunction. Those rates are usually higher after surgery, but the cancer treatment in and of itself can interfere with the plumbing, so to speak. I didn't say 100% of people avoided the surgery. So there is a risk that the cancer can grow. And unfortunately, fortunately, most people are able to have surgery if the cancer grows on that watchful period. I guess, unfortunately, some patients do develop cancer distantly or metastatic disease. So there's a bit of a risk there. The key patients would be patients who are motivated and would be willing to undergo all of the follow-up tests, right? So, close follow-up would be MRI and a CT scan, so imaging, as well as being scoped, or, having the camera to take a look in the bowel on a regular basis, and physical exam. And so logistically may be more challenging if patients live far away from a cancer center, time off work, and it only, it's a team effort. So the patient would have to agree to undergo all of those follow-up tests and take time off work for that, right? If they're working.
Yeah, very interesting. I think I heard you saying, correct me if I'm wrong, about 54% based on the trial.
Yeah,
that's a very promising number, isn't it?
Yeah. So again, they did pick good patients, so not patients with very locally advanced disease, large tumor, other structures, lots of lymph nodes involved on imaging. So unfortunately, not everybody is a candidate, but for certain patients that we have protocols for that.
Right. And just to reinforce, I think what you've said, while there's certainly benefits of non-operative approaches, there's also demands on a patient that perhaps might outweigh having the surgery. So that's a conversation that you would have very intimately with your patient.
Mhm. Yeah, so often either the patient brings it up after the surgeon talks about the surgery that would be involved, or the surgeon notices that you've had a complete clinical response. You know, this is an option, right? We could, rather than proceed to surgery, do you want to? So there's two ways to go about it. One is the patient brings it up. The other is the surgeon's like, wow, this was a home run. You know, how would you like to proceed?
Right, perfect, great. Thank you for that. Dr. Chen, I'm going to bridge to another conversation, and I'm going to introduce some language that some members of our audience may be only surfacely familiar with. But if I use language like MSI high, what exactly does that mean? What are the implications of that for somebody who's just particularly been diagnosed? Maybe you can help shed some light and educate us on that.
Thank you, Anne-Marie. So MSI high refers to the fact that all of us have this small fragments of DNA in our genome, and in some patients that the number could be increased. So what does that mean? That means that in those patients that they have the lack of the ability to repair damage in their DNA. So as a result of that, those patients have a risk of developing cancers such as colorectal cancer, gastric cancer, endometrial cancer, ovarian cancer. And so in the colorectal space, about the 10% patient has the MSI high. So there's also lots of data to say that because of those patients' lack of the ability to repair DNA damage, those patients are highly responsive to immunotherapy. So not the traditional chemotherapy, but they're highly responsive to immunotherapy. So there have been a lot of research going on in patients with metastatic disease and also in patients with localized disease in both settings, that it seems that MSI high patient respond to immunotherapy very well. So this is why there's so much excitement in oncology, especially in the GI oncology in the last few years.
I see. And did I hear you correctly? You have to have a DNA test to determine if you're MSI high?
So there's a number of ways to do this testing. So yes, a DNA test, just like when we are testing patients for their RAS/RAF status, so that it's a testing of your DNA, but it also can be tested in other way called immunohistochemistry, so that is commonly done after the initial biopsy or surgery, and that is really the standard of care in Canada right now.
Okay. Dr. Kara Nicholas, maybe I can bring you into this because I understand you're surgically an expert actually in MSI patients, and maybe you could talk a little bit about some of the surgical considerations for an MSI high patient.
Sure, thanks, Anne-Marie. So as Dr. Chen said, it is relatively uncommon to see patients who have cancer that is MSI high. It's also quite uncommon to see patients with liver-only metastases. So most of the time that we think about surgery in the metastatic setting, it's for patients who have liver-only metastases. Things have changed a little bit, I would say, recently in the context of MSI, a better understanding of MSI high patients and treatments for them. And what I mean by that is immunotherapy is a treatment option now for patients whose cancers are MSI high. And with immunotherapy, it's quite common to see very deep responses, so very good responses to treatment, and they can be quite prolonged, even so much so that one might consider surgery even in the context of cancer outside the liver. So I think that's one area that the field, I think, is quite rapidly changing. to be honest with you. So I think there's a lot of recent evidence coming out. First of all, suggesting that we may not need surgery at all. So for patients who have liver metastases and they are MSI high, it's quite possible that with immunotherapy, we may eliminate the need for surgery if they have a very good deep response. So that's one scenario that might be very good for patients. Another scenario is for a patient who might not traditionally be thought of as benefiting from liver resection because they have cancer outside the liver. If the cancer is MSI high and they receive immunotherapy and they have a very good response to that, and really the only cancer that's left seems to be in the liver, that might be a situation that we might recommend some sort of treatment to the liver, either surgery or other specific treatments to the liver like ablation or radiation to try and treat whatever remaining cancer is alive.
Yeah, because we're on the subject, I'm going to stick with you, just if you don't mind, Dr. Karen Nicholas. There's terminology, and I understand it's a specialty at Sunnybrook. There's an HAIP, chemotherapy clinic. Have I got that language correct? You can talk a little bit about what that is.
Sure. So yeah, we love our acronyms in medicine.
I know, that's, and you can share with our audience the long form of that, please.
Sure. So the liver is a unique part of the body in several ways. And this has been recognized for centuries. I would say that it's unique in a few ways. One important way when it comes to this treatment is that it has a dual blood supply. So it is supplied by two sets of blood vessels, one of which is an artery that supplies most of if there's cancer in the liver, that's mainly supplied by the artery. And it's also supplied by a vein that actually supplies most of the normal liver. So that's one important feature of the liver. The other is that the liver is a very strong filter, and it's a filter when you eat food. Basically, things pass through the liver so that toxins are filtered out before reaching the rest of your body. So if you put those two features together, they actually allow a unique treatment paradigm for cancers of the liver. And what they allow to be done is certain types of chemotherapy drugs can be injected into the hepatic artery, which, remember, supplies mainly the cancer in the liver, not the normal liver. And if it's a specific type of chemotherapy, it will be filtered out by the liver before reaching the rest of the body. So there's one specific type of chemotherapy called FUDR, another acronym, unfortunately, that when it's put into the hepatic artery, almost all of it stays within the liver. So very little of it goes to the rest of the body. And that allows a much higher relative dose to be given when it's delivered that way compared to when it's given in the traditional way, which would be through a port or a PICC line intravenously, because in that situation, it flows all throughout the body and only a very small percentage of it ever makes it to the cancer. So for a patient who has colorectal cancer in the liver and nowhere else, or generally speaking, very few other places outside of the liver, in some ways, it doesn't make a lot of sense to be giving them chemotherapy through a vein, having it travel all throughout the body, having side effects to the whole body, and only having a very small percentage of it actually making it to the cancer that we want to treat. Like, that's not philosophically great. So what this treatment allows, it's hepatic artery infusion pump chemotherapy. It's a treatment where we do an operation. We put a special type of pump in underneath the skin, overlying the abdomen, with a catheter that goes directly into the hepatic artery to the liver. And then we fill it every 2 weeks, and we use a special type of drug called FUDR that essentially all of it stays within the liver. And it allows us basically to just give a much higher dose to cancer within the liver than we would be able to give when we deliver via the intravenous. And we offer that treatment to select patients who we think are likely to benefit. And those are patients who have colorectal cancer that has spread to the liver and really nowhere else other than the liver, or with the exception of very small spots within the lungs, because those can generally be controlled as well. And when we cannot do an operation to remove the cancer in the liver, so in other words, in patients who are unresectable, that would be a time that we would consider this treatment for them. And in that situation, we see very dramatic responses, so generally very good responses, better than what we could see with intravenous chemotherapy. And in some cases, it may allow us to get the cancer smaller, even to the point that we can then do an operation to remove what's left.
Very interesting. How accessible is this therapy, this approach?
So currently in Canada, we are the only center offering this treatment in Canada. And that's because there are several logistic challenges to doing so. Up until recently, it's only been offered in 4 or 5 sites in the world. But over the past several years, it's kind of exploded across the United States. So there's currently over 60 centers in the United States and many others in the rest of the world offering it. Unfortunately, we're still the only center in Canada offering it. So it is a little bit limiting. And in part because also it does require treatment to our center every 2 weeks. So currently it's only available to patients who live in Ontario. We do have patients from all areas in Ontario. If patients live outside of Ontario, there are possibilities to be treated at centers in the United States. Obviously, there are logistic issues associated with that, but I would suggest that if patients think this might benefit them, they could speak with their medical oncologist and explore that with them.
Thank you very much for that clarity. You know, in sessions like this, there's lots of complicated language that oftentimes gets discussed. And Dr. Tang, I'm going to ask you, if you wouldn't mind, please, to explain the difference between immunotherapy and chemotherapy, you know, to an average person who's just really been on the beginning of their journey. Is there a difference between those two things?
So right now, for curative intent colon and rectal cancer, we focus mostly on chemotherapy, and usually we would call that cytotoxic chemotherapy. Luckily, most of our curative intent treatments cause minimal hair loss, but they do cause your white blood cells, which fight infection, platelets, which help your blood clot, red cells, which carry the oxygen, those can drop. And so that's our traditional chemotherapy. And, you know, nausea, those things that we hear about and we associate with chemotherapy. There are clinical trials evaluating newer agents, but for standard of treatment, it's all cytotoxic chemotherapy for adjuvant colon and rectal cancer or curative intent treatment. So for metastatic colorectal cancer, that's where we bring out our other toolbox. And based on standardized testing available throughout Canada, we can identify certain tools in our systemic therapy toolbox, which will be useful. For example, we heard from Dr. Chen about MSI high and mismatch repair deficiency. So if a metastatic cancer patient had mismatch repair deficiency or microsatellite instability found on a test on their tumor, we do all this testing on the tumor, then we could give them immunotherapy. And so immunotherapy, what that does is it takes the brake off our immune system, and cancers that are microsatellite unstable because of those problems with repairing the DNA, their cells are funny looking. I'm just going to use words that all are
That's a good word.
Will understand. The cells are funny looking. And so the immune system, now that the brake is off with the immunotherapy, says, these are funny looking cells, I should attack it. So we get our immune system, the patient's own immune system, to attack the cancer. And that's why the responses are deep, meaning the cancer shrinks a lot because the immune system is like, oh, still funny looking. And your immune system, the patient's immune system, will attack the cancer. And also prolonged, because it's just like being vaccinated, right? your immune system's like, oh, these are funny looking cells, I should attack them, and just keeps looking for them. So when it starts to grow again, the immune system just swoops in and takes care of it like an infection. And because it's your immune system doing the attacking of the cancer, it's usually very well tolerated. And the side effects are if the immune system goes overboard and attacks a normal part of the patient. But those are usually quite rare, and we know how to follow them for that. And then based on other testing that we do on the tumor, we may be able to use targeted therapy, which has different side effects from the chemotherapy I talked about. And sometimes we use targeted therapy with chemotherapy together. So there's lots of options in our toolbox for cancer patients, and it's based on standardized testing that we do on all patients across Canada when they first present with metastatic disease.
Thank you for such a beautiful explanation. Appreciate that very much. Dr. Chen, I want to come back to you, and I'm going to ask you to celebrate some of the work you're doing on something called an Azure trial, which is very promising. So tell us about that. What stage is it? Is it open for patient participation at this stage? Help us understand more about these beautiful trials.
So we have been talking about rectal cancer and MSI high patients. So that, as I said, that in about 10% patients with early rectal or colon cancer has MSI high, and so there have been a lot of research done recently showing that those patients could respond to immunotherapy very well, and in those patients that they may need it in the old days, well, they may need chemo, radiation, and surgery, and but now that if we give them immunotherapy, that the cancer could disappear, and so those patients could be saved from all this chemotherapy, radiation, and surgery. So that's why that there are a lot of efforts going on in this areas that to prove that those preliminary results can be applied to a much larger patient population. So that's why there are several clinical trials going on. So there's one in locally advanced rectal cancer, so patients with other T3 or T4, so the cancer touching the wall of the rectum or have lymph node involvement, that they could be treated with immunotherapy. So Dr. Tam a couple of months ago sent us referred a patient from Calgary to us, a young patient, lots of pain from rectal cancer, that he can't even fly without pain from Calgary to Toronto. So he participated in the study. After one treatment, that his pain improved dramatically, and his pain medication requirement reduced, and his bowel movement have improved. So we are seeing some good results, very promising results from this group of patients with immunotherapy. So there's another trial,
I'm sorry, Dr. Chen, that's what's called the Azure trial.
So that's Azure 1.
Yes.
So there's a Azure 2. So it's the same patient, same MSI high patients, but in colon cancer, not rectal cancer. So those patients are going to be treated with immunotherapy, or they could have surgery and chemotherapy afterwards. So again, the purpose is to compare those two approaches and see whether immunotherapy actually works better than surgery and chemotherapy we traditionally would give patients.
Okay, thank you. So this is a cross-Canada dialogue. So if there's members or folks who are listening to this who can speak to their oncologists about it, they would have access to the trial. Is that the way we can say this?
No, absolutely. We even talked with the sponsor of the trial, so the pharmaceutical company sponsoring the trial, that patients, we're actually paying patients travel expense that we're able to cover their travel expense so that so they do not have any out-pocket expense if they wish to explore this option.
Yeah, yeah. Dr. Tang, I'll let you have the last word on this because it sounds like you very successfully referred a patient into the trial.
I think it's a great way for patients to access a very promising new treatment. And across Canada, we usually do this mismatch repair or MSI testing upfront, so we know the answer quite quickly at the time of consult. So very easy for us to refer rectal cancer patients. I think the colon cancer patients, we would be happy to help with. Just needs more engagement of our surgical colleagues across Canada because they're usually the first people who see the colon cancer patients. But I think this is an example where Canadian patients, especially with the drug company being very, very generous, would have a fabulous opportunity to access this novel therapy.
Great. Thank you very much for reinforcing that. I'm going to bridge subjects. Again, language that is oftentimes used in care, biomarker testing, genetic testing, ctDNA testing, lots of language in here. So maybe we'll break that down a little bit, or you can help us break this down. What exactly is biomarker testing? Does everybody who has had a cancer diagnosis require this? Dr. Chen, maybe we'll let you start and we can go back and forth. I think we've lost Dr. Karen Nicholas. Is he still on with us? If somebody could let me know, that would be fantastic. But please, Dr. Chen, I'll let you go. You'll take the first go at this question. What is biomarker testing and who should get it?
Okay, so traditionally, we think that cancer cells are all like each other, right? So that they are all the same. But if you think about it, 1 centimeter tumor cells has 1 billion cancer cells in it, okay? So with that many cancer cells, that now that we realize that there are differences between those cancer cells, right? And also there's a difference between cancer cells from one patient to the next patient, right? So before we give every patient cytotoxic chemotherapy, like Dr. Tan mentioned, but now that we realize those differences in patients, so that we need to find out what those differences are, and so that we could tailor treatment to each patient depending on their cancer type. So although those cancers are all called colorectal cancer, but they may have subtle differences, and there's differences in their DNA. So that's why we do the biomarker testing of their DNA, trying to find out what's the difference. So MSI testing is one biomarker testing, and there's other biomarkers such as RAS mutation and RAF mutation, so that now there's drugs that targeting those biomarkers so that the patients could be treated differently depending on those markers. So hopefully that one, we will get better results from the tailored, individualized treatment. Two, we could reduce the side effects of our treatment.
Very interesting. And so does every patient have to have a biomarker test? Is that available to every patient?
So as Dr. Tam mentioned that for all patients with colon cancer and rectal cancer, at least at the time of diagnosis, MSI testing is the standard of care. But for patients who have colorectal cancer, which has spread to other parts of the body, so metastatic disease, there are different targeted therapies. So those patients definitely need more biomarker testing, such as RAS mutation, such as RAF mutation, and such as HER2. So So those are important information for patients and for oncologists to know, so that we could tailor individualized treatment.
Very good. Dr. Teng, did you want to add anything to this conversation?
I think I just want to say that not all, for example, in Alberta, we are not able to access HER2 testing for metastatic colorectal cancer, and that's because the HER2 directed therapy is not part of is not funded nationally. Like, it's not standard of care. It'd be something you'd be exploring from either on a clinical trial, or if a patient had insurance to cover out-of-pocket medical expenses. So in Alberta, anything that is not Blue Cross, for example, to cover medication bills might cover something such as HER2 targeted therapy. But rest of the testing is standard across Canada. And then I guess your other layer of questioning would be genomic testing.
Yes, thank you for being
and
there.
then I'll let Dr. Chen answer about circulating tumor DNA, but I'll take the genomic issue.
And lots of terminology. We're just trying to
Yes,
break
yes.
down to help everybody.
So most of the time we do genomic testing on tumor tissue, and usually it's something that was, done as standard of care, that procedure. It's in some provinces offered as a panel and available as standard of care. So in British Columbia and Ontario, Manitoba, and Halifax, they have these panels, which are standard of care for metastatic colorectal cancer patients with cancer spread outside the bowel to liver or lung, for example. And the reason that it's not covered everywhere is these genomic testing. I try to explain it. It's like looking for flags in the cancer, and these flags are directing the cancer's growth, identifying, a pathway that the cancer uses to grow, these flags. But we don't have a drug for every flag, and that's why it's not available across Canada. And if we have a drug associated with the flag, so for example, there's a blue flag on this cancer, and even if we have a drug that treats a blue flag, for example, just because you have the blue flag doesn't mean that you'll respond to the blue drug. So we don't have a perfect match yet. We're trying to personalize medicine. That's always our goal, but our science hasn't quite caught up to that. So if you do the genomic testing, you're looking for flags, and some flags have a drug associated with it. But sometimes just having the flag doesn't mean you'll respond to the drug. And a lot of times, because we haven't proven that patients will feel better or live longer by treating them with, for example, a blue drug, if your cancer is a blue flag, those drugs are not funded nationally. So those are, again, out-of-pocket expenses that you would need extra insurance for. Or if you're able to access those types of drugs through a clinical trial, and that would be another reason to do this testing. So there are some disparities in care, but that's because that level of care hasn't been proven to help people live longer and feel better. So these are ways that we can help personalize medicine, but it's an emerging science. We're trying to learn. It is unfortunately not available everywhere, but there is the option to pay out of pocket for this genomic testing. But again, it's your unfortunately out of pocket costs.
Yeah, no, thank you. You have a beautiful way of expressing things, and it's really the ability to help people understand what's standard of care, what's not standard of care, the implications of not standard of care. And I might add that organizations like Colorectal Cancer Canada are very well versed in helping patients to, let's call it, maneuver and understand these very complicated conversations. Of course, the medical team is increasingly competent and able to do these as well, but fundamentally patient groups are in place to be able to help with these conversations. But so we can say today that biomarker testing is pretty much standard of care. Is that a fair comment? Whereas genomic testing may not be. Okay, is that a fair comment?
Perfect.
Okay, perfect. Thank you. We've only got about 5 minutes left. And it seems to me, he's back. I'm so happy. We understand you had a little bit of a computer crash. Hope you're okay.
I'm doing fine, thanks. I don't know about my computer, but I'm feeling fine.
Okay, very good. And we've got about 5 minutes left, so your timing is impeccable because I want to get into a brief conversation around building the very best relationship possible between a medical care team and a patient and the family care team, and how, particularly in today's world, a relationship can be built solidly between an oncologist, a patient, and the patient's caregivers. And just some of your own personal experiences in situations where you've really valued the relationship you've built with the patient, their caregivers, what that looks like, the kinds of questions that you would want to ask a patient would want to ask you. It's all about establishing a really fantastic relationship. So, Dr. Chen, maybe we'll start with you, and just to give Dr. Karen Nicholas a chance to regroup with us, and then I'll ask you to finish us off, Dr. Tang.
So I think that a cancer diagnosis and treatment and dealing with side effects from the treatment, dealing with emotional distress associated with a cancer diagnosis are all very difficult to navigate. So I think that not only for physicians, but especially important for patients and caregivers. So I think that having open dialogue and discussion, I think it's important. So from my end, I always ask patients to bring extra pair of ears, bring a family member, bring a friend to their appointment, so that when you are distressed, you may not remember what we discussed, but I help to recall what was discussed afterwards, right? So that, but I think that the open discussion is a critical piece of how we dealing with this diagnosis and the treatment.
Thank you so much. An extra set of ears. That makes great sense to me. Dr. Karen Nicholas, what would you say?
Yeah, I agree totally with Dr. Chen. I think the relationship between a patient, their entire care team, and their doctors is critical. And I think it's just like any other relationship. Sometimes things work, sometimes they don't. Sometimes two people gel and sometimes they don't. And I think it's great to enter into things with an open mind. It's great to come prepared and have questions. And I think it's important to ask your questions, be honest, be open, realize that you're getting into a relationship, and many times a lifelong relationship, and approach it as you would any other relationship. And I think it's also okay if it doesn't work to ask for somebody different, because I think that is somebody, or a group of people who are going to be very important to your life. And I think it's important to empower yourself that if the relationship is not going well and you're just not feeling comfortable, I think it's okay to ask for somebody else, because it is important that you have a strong relationship with your providers. You need to have trust in them. They're really going to be part of your team moving forward. And so I would just encourage people to be empowered to take that and make sure that they're comfortable with their team.
Thank you so much for raising that very important point, because I think people don't oftentimes feel that they have a choice. But if things are not going well and there isn't a relationship being built, as you say, for a lifelong situation, it's okay to reach out and look for alternatives. Thank you so much. And Dr. Tang, you have the last word here.
So I agree completely. Communication and trust are important. Honestly, we just need our patients to show up to the appointments and let us organize everything. We have the patient's best interests at heart, and we're hoping with them for the best outcome possible. Thanks.
Yeah, I can say wholeheartedly that there's extraordinary people across the system, like the three of you, who are working very, very hard every single day to be the very best they can be on behalf of their patients. So I want to thank you so much for your time, your openness, your authenticity today. Dr. Tang, Dr. Chen, and Dr. Karen Nicholas are here for your questions, and we're going to go to those now. That was an absolutely outstanding session with an amazing amount of information. We've got about 13 minutes to answer what are dozens of questions coming from the audience, and we're so pleased that everybody has made a contribution and made an effort to provide a question. If we don't get to your question today, I promise you that the wonderful team at Colorectal Cancer Canada will get back to you with an answer to your question. But I'm here with Dr. Tang and Dr. Chen, who are very, very happy to take as many as questions. So I'm going to, without further ado, go right into it. So the very first question we have here is, what does immunotherapy entail and who actually qualifies for it? Dr. Chen, I'm going to throw that first question to you.
Thank you, Emery. So right now that immunotherapy is still like getting a drug. So that the drug is usually given intravenously every 2 weeks or every 3 weeks. So for now, that the only patients who are benefiting from immunotherapy is those who are MSI high. So that is about 5 to 10% patients with colorectal cancer. But there's a lot of research looking at the other 90% patients, so the so-called MSI stable patients, to see whether we can make immunotherapy work in them as well.
All right, thank you. And I guess perhaps a build on that question, or that one question is the next one, was that, is it possible for a patient initially not to be MSI high? However, through the course of their disease, their cancer type mutates to MSI high?
It would be pretty unusual for the cancer to change. It's something that wouldn't necessarily change between your initial presentation. For example, with a curative colon cancer, it wouldn't change with time, and it wouldn't necessarily change if, unfortunately, someone developed metastatic disease. It's something that is quite stable feature of the cancer.
Okay, perfect. Thank you. In non-operative management, how quickly are CT scans or other imaging scans able to pick up cancer reoccurrences if they happen? I'm going to guess the answer is fairly similar between the two of you, but who'd ever like to pick up on that? Welcome.
I think that
You go.
So the technology, the best technology we have right now is CT scans, right? So usually, but when you think about it, a 1 centimeter tumor we see on the CT scan has 1 billion cancer cells in it. So that means that if we are dealing with thousands or even tens of thousands of cancer cells, we are not going to see it on the CT scan. So this is why new approaches are being looked at, such as ctDNA. And but to really answer your question, that the CT scan is not a perfect test and is not picking up recurrence as early as we would like, but it is the best technology we have right now.
Great. Well, thank you. And it's a perfect answer to bridge into the next question, which is, would the availability of ctDNA make the surgery sparing approach more feasible?
I think that is something under active investigation, but not necessarily ready for prime time yet. So, that space is definitely evolving. But I think we would rely on our, having regular endoscopies, physical exams, and imaging for now. And maybe in the future, we can refine the ctDNA technology so it's a better test.
Yeah, thank you. I'm going to ask there's actually two questions that are very interrelated here, and you may both have a different approach or perspective around this, but how might you address a patient who wants a second opinion? And the pairing question with that is, in Ontario, what's the process for requesting a different oncologist? It may be different. Of course, Dr. Tang, you're in Alberta, Dr. Chen, you're in Ontario, but this issue of wanting a second opinion, number one, and if you do want to change oncologists, is there provincial differences, or what is the general approach? And is there in fact provincial differences around that? Dr. Chen, do you want to start with this one?
Sure. Yeah. So I think that, thinking about change your oncologist is not an uncommon phenomenon, and especially for patients who are dealing with such a serious diagnosis and the implications for prognosis, right? But I think I want to reassure everybody online that in Canada, our treatment, regardless where we are pretty uniform. And I think that in contrast to some other countries, oncologists in Canada follows guideline reasonably well. So that I think that I just want to reassure everybody that the treatment you get in are the best standard treatment available anywhere in the world, with few exceptions, such as when you have a rare mutation that you may be eligible for a clinical trial. But to answer your question, that if you want to switch oncologist, that usually the best thing to do is talk with your family physician, and even talk with your own current oncologist and talk about the clinical trials and talk about getting a second opinion. So at Princess Margaret, we actually have a senior oncologist who actually specialized in providing second opinions. So he has a clinic especially to provide the second opinions to patients actually throughout Canada.
That's very interesting. And Dr. Tang, I'm going to bring you into this conversation because I think it's an important area, especially with the pressures on the healthcare system today. Many people probably don't feel comfortable, like, oh my gosh, I already had a hard enough time getting to one oncologist. What would be the circumstances under which somebody should feel comfortable in requesting a second opinion?
I completely agree with Dr. Chen. Across Canada, we follow the same guidelines and we have the same drug availability. So what you get in Newfoundland will be the same in British Columbia. I think a second opinion is if the therapeutic relationship is broken, right? So that there's it's a more, I think personally, about the interaction between the physician and the patient. If something in that relationship has been unfortunately damaged, then I think, that makes a second opinion, the only way to get a different relationship with a different physician. I think if you just want reassurance that about the treatment plan, you could just ask for your case to be discussed in multidisciplinary rounds. And then I did pick up on the clinical trial question. You can always ask your own oncologist upfront, are there any trials available here at the center you're being seen at? or is there something available elsewhere? Just understanding that clinical trials are like taxes, so there's a lot of criteria. And once you start on a treatment, you may have become ineligible for a trial in that space. So we're not trying to make it complicated, but it is very much like taxes. So it's basically the best opportunity to start participate in a clinical trial is if you're not on treatment or you're about to change treatment, right? So definitely, feel free to ask your oncologist because sometimes it's a prompt. I hope that answers that question.
Well, thank you. And you did a beautiful bridge into the next question. So on the issue of a second opinion, our audience should know that people can feel comfortable in having a direct conversation with their family physician and or their current oncologist. There's options that exist, even in terms of having multidisciplinary review. So that's great. And thank you, Dr. Tang, for going right into the clinical trial question, because I think, people in general understand the concept of trials, but like at what point does one consider going into a trial? And once you do get into a trial, what are some of the expectations around that in terms of monitoring and follow-up care? Maybe Dr. Chen, I'll let you build on some of the things that Dr. Tang has already introduced here around clinical trials.
So again, I agree with Dr. Tan that clinical trial is an option, and I think that one can investigate clinical trials at every stage of your diagnosis and the treatment, right? But the clinical trial does have a lot of criteria, so that at one stage of your treatment that you may not be eligible for a clinical trial, or we are not considering until we are switching on treatment. But again, I think that in Canada, oncology is a relatively small community. We work together very closely, and we all know that what is going on in Canada, so that your own oncologist is probably the best sources if you are interested in clinical trials. For example, Dr. Tan and I worked very close together, and right now I have 2 patients from Calgary participating in clinical trials in Toronto. So, it's because that she knows what's going on, and she's watching out for patients who might be eligible. And then when she sees those patients, she will refer those patients to us, right? So that talking with your own oncologist is probably the best way to have that conversation.
Yeah. Thank you very much. All roads do lead back to the oncology team that you're working with. What's interesting when we have this important discussion about drug development and therapeutic development and evolution, the world is changing very, very fast. Both of you are experienced oncologists. You've seen so many things. How might you characterize some of the improvements that you've seen in terms of prospects and outcomes for metastatic colorectal cancer patients over the years? And why exactly is that? Have they?
So I would say in the beginning there was 5-FU and they would vary how to give it. And then we added irinotecan, oxaliplatin, bevacizumab, panitumumab, and now we have all these molecular subsets, treatments specific for BRAF, metastatic colorectal cancer, mismatch repair deficient colorectal cancer, emerging treatment for HER2 positive. And this is because of clinical trials. This is because patients have participated in clinical trials that now I think, depending on your molecular subtype, median survival is over 3 years for many patients. Of course, unfortunately, that's average. Some people do better, some people don't do as well, depending on their subtype, but it's because patients have participated in clinical trials, and we can't thank patients enough for that participation.
Yeah, thank you. And unbelievably, we're at time on the Q&A. And so again, I want to encourage our audience to, if they do have further questions, to reach out to the team at Colorectal Cancer Canada. Very happy to answer any questions you have, give you the connections that are appropriate for you. And in the meantime, Dr. Tang, Dr. Chen, thank you again very much on behalf of our audience, on behalf of Colorectal Cancer Canada for joining us today.
Thank you, Anne-Marie.
Thank you.